Good morning, everyone. Today I'm presenting an innovative technique of mini SLET, a case series. Simple limbal epithelial transplantation is a surgical technique that restores the ocular surface in patients of limbal stem cell deficiency. But one of the very common issue with the classical technique is displacement of the limbal pieces. So how to overcome it? A sandwich technique was involved using the second AMG, which can be placed over the limbal pieces so that they are not dislocated. But the problem with this, that the second AMG is not cheap, especially with our clientele. So our surgeon, the surgeon who has done this innovative technique, thought of why not we place the limbal tissues directly over the raw cornea and then place the AMG so that they are not displaced and there is no increase in the price. This technique was used in 2 pediatric patients. Both were males involving the left eye because of the Lyme injury. The pre-op BCVA in first patient was 6/36 with astigmatism of minus 3.5 diopters at 70 degree, and second patient with the pre-op BCVA of 6/60 with the pre-op astigmatism of minus 4 diopters at 65. Both patients has partial limbal stem cell deficiency with no initial corneal surgery and wet surface, but the patient 1 also have an additional symboliferon. The initial step of harvesting the limbal tissue was same as the conventional SLET technique, but on the recipient eye, initially the pannus was removed and then the limbal tissues were placed over the concerned area. This diagram is actually showing the whole cornea, but in these cases, the limbal tissues were placed over the concerned area and then the AMG was placed. Since case 1 also had the symboliferon, so we have used the conjunctival autograft in that area. The results were pretty comparable to the conventional SLET technique, with good visual acuity at 9 months post-op. For discussion, it is a very common problem with the displacement of limbal tissue, especially in children, which is about 5 to 7%. So we can even thought of using a BCL, but the problem in pediatric patients is there is a high incidence of epithelial cell growth on the contact lens, plus they can even lose the BCL also. So to reposition these, the pediatric patient has to undergo another OT session because it cannot be done like in minor OT as adults. This study has proof that as AMG provides a conductive niche for progenitor cells to proliferate, the same can be provided by the corneal stromal surface. The AMG prevents the dislodgement of the limbal tissues. This modified is reported for the first time in India, especially, though the sample size is very low, but this requires future studies to validate. But the point is, this can be used as a breakthrough technique, especially when we have a poor clientele and we don't want the pediatric patient to undergo the second general anesthesia setup. Thank you.
Did you still put a bandage contact lens over the amniotic membrane graft?
No, ma'am, we haven't used BCL over these 2 patients. It was just the AMG.
I'm not very clear about the technique. When you put the limbal explants, did you put glue or you just put them and put the amniotic membrane on top of it?
Ma'am, sorry, I can't hear you.
Did you use glue to fix the
Yes, ma'am, we have used the glue for putting the limbal tissues, and over that we have put the AMG. Because what we have seen is even after the glue, because kids have a habit of rubbing their eyes or playing, there was very history of 5 to 6% chances of losing the limbal tissues. If not losing, at least there was displacement of the tissues. So this technique was helpful, especially for pediatric patients, not for the adults. This is good for pediatric only.
And have you compared maybe with the OCT the anatomical outcome between these?
Ma'am, actually these cases were done where actually I'm from an army setup. We didn't had the OCT to do the AS-OCT or any further investigations. It was basically on the slit lamp examination only.
And you have not noticed any morphological difference between the traditional technique?
No, ma'am.
Means you put the limbal pieces just
on the
cornea
with the glue,
and then you are putting one amniotic membrane. And what was the orientation of amniotic membrane? Epithelial side up or
epithelial
down?
side up, ma'am.
Epithelial
Side up only.
Why did you say it's sandwich? Because there is only
No, ma'am,
one...
it is not sandwich, but a sandwich technique was tried in which first they put the AMG over the cornea, then the limbal pieces, and then another AMG. But that we cannot use in our clientele because EMG costs a lot. So using 2 AMGs, because our clientele is very poor. So that is why the surgeon thought of maybe using only 1 AMG.
But in your case, you're putting limbal stem cells on the raw
Yes, ma'am, on the raw cornea.
without any epithelium, and then you're putting amniotic membrane which has epithelial
Epithelial
side
side
up. So where is the scaffold for growing limbal stem cells? Because limbal stem cells are in touch with raw cornea and the stroma of the amniotic membrane. There is no epithelium to for the reepithelialization.
But that's what the suspicion is. Maybe the stromal surface of the cornea has acted as a niche for the progenitor cells to proliferate. That's what we want further studies to validate our suspicion. That's the suspicion of the surgeon, that maybe it's the stromal surface that act as a niche rather than having a AMG.
Were any sutures used?
Sorry?
Were any sutures used to
No,
harness
ma'am.
the
No sutures were used. We have only used the glue. Even for the conjunctival autograft, the glue was
did
only
you
used.
follow up the patients? What was the time for absorption of the amniotic membrane graft?
Ma'am, absorption actually, we have followed them till 9 months. It was not fully absorbed, but there was no any calcification also was not there because we were regularly following that monthly. Initially, they were followed weekly and then they were monthly till 9 months.
Okay, so there was no displacement of
No,
the
ma'am.
amniotic membrane despite no BCL and no
No
sutures.
BCL was used, ma'am.
This technique has been reported, as you said, not in India, but
Ma'am, actually, it's a published case.
yes.
Yes. So
right.
I
Thank you.
published it last.